You got a few bills to drop, right? Okay. Okay. Let me know when. Okay. Good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I want to thank everyone for coming on time. We really appreciate it. I am Jocelyn Pena-Milnick, the chair of the Health and Government Operations Committee, joined by my wonderful vice chair, Bonnie Collison, to my left. I kindly ask for your patience if we encounter any technical streaming issues. Please set your electronic devices to vibrate. If you're having a conversation, please go outside. As a reminder, there's no food or drink allowed in the gallery because then staff has to clean it. You'll see that we do drink because we're here for hours and we have to stay hydrated, but we're responsible to take our own stuff to the back as well. What is it? Tea, coffee, or soda? For each bill that you'll hear today, we're going to hear from the bill sponsor. And I know we have some amazing, beautiful young people in the audience today. The bill sponsor are the people that are bringing forward the bill. And the sponsor panel, they have people that are supporting it. And then sometimes we'll have people that are opposing it. And they'll testify with favorable, meaning they support it, favorable with amendment, they support it, but they want to see a change. Unfavorable, they do not want the policy to be approved. We also have virtual witnesses, so you'll see some in person and some online, and they'll testify in the same manner, favorable, favorable with amendment, and unfavorable. The bill sponsor in this committee is not limited, but we really like them to be considerate and not abuse it. Otherwise, we have to stop them. While all witnesses, the other witnesses have 2 minutes to provide the testimony. A timer is displayed on the screen and a sound will play when the time has expired, which is 2 minutes. And for the committee, you have all been doing wonderful. Thank you so much for your questions and for the respect that you give the witnesses. Please adhere to our usual committee rules of 1 question and 1 answer, and please keep your questions brief. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. Today, we will hear the bills in the following order. The first one is House Bill 42, Public Health, Public Service and Protections Revisions. The second is House Bill 57, Prescription Drug Monitoring Program Dispensers, Veterinarians. House Bill 127, Public Health, Non-Occupational Post-Exposure Prophylactic NPEP, Standing Order Program Establishment. And the last bill of the day will be House Bill 358, which is a bill from the Prince George's County Delegation, Prince George's County Work Group on Health and Wellness, PG 4924, and that is Senator Muse. So let's start with House Bill 42. And if I may ask the department to come forward and bring your panel as well, if there's anyone supporting it. Good afternoon.
Good afternoon.
Long time no see.
I know.
It is great to see you in this new role. Tell the committee your name and your new role.
I certainly will, Chair Pena-Milnick. It is very good to see you, Vice Chair
Thank
Collison
you.
as well. I'm Dr. Nilesh Kalyanaraman, the Deputy Secretary for Public Health at the Maryland Department of Health, and it's a pleasure to be here with you today. For House Bill 42, this is a departmental bill that contains 5 components to improve, align, and streamline our work at the Maryland Department of Health. The first element is to align Maryland law with federal law concerning the sale of tobacco products to active duty military personnel under the age of 21. The General Assembly passed our Tobacco 21 bill prior to the federal government doing so, and our statute includes an exemption for active military duty personnel from ages 18 to 20.
Thank you.
Right now, under federal law, it is not legal to sell tobacco products to anybody under the age of 21, and this bill would align our law with federal law, which has supremacy. The second is to allow the Maryland Department of Health to shift unspent cancer prevention, education, screening, and treatment funds from counties that cannot spend them in a fiscal year to counties that can use the funds so that we can best serve residents. The third element is to allow the Maryland Department of Health to eliminate a redundant report. Currently, the department has to submit a report on our cigarette restitution fund, counter marketing and media activities, in addition to our comprehensive annual CRF report, which already includes this information. Eliminating the redundant counter marketing and media report would help streamline our reporting without any loss of information. The fourth is to allow Maryland Department of Health to eliminate a redundant panel. MDH has been required to convene an expert panel on child abuse and neglect and submit data annually. This bill would require the State Council on Child Abuse and Neglect to coordinate with the Child Abuse Medical Providers Initiative, the CHAMP initiative, to include this data on child abuse and neglect as part of their work. And lastly, this bill would transfer responsibility for the payment of claims for emergency medical treatment for abused and neglected children from the Maryland Department of Health to the Governor's Office of Crime Prevention, Youth, and Victim Services. And this would align state law with existing practices as they have been processing and paying these claims for several years now. Thank you for your time, and I'm happy to take any questions.
Thank you. Next, would you like to testify or you're?
This is Elizabeth Crom. She is the director of our Prevention and Health Promotion Administration, and she's part of the panel to help answer any questions.
Okay, wonderful. And before we get to the question, who may I ask the young students, what school are you representing today? Okay. Okay, wonderful. We welcome you to the Health and Government Operations Committee. Thank you for being with us today. And this is the committee that deals with all the health bills. So we're going to open it up for questions now from the committee. Are there any questions for Delegate Kaiser?
Thank you, Madam Chair, and thank you. I see on the sign up that the Department of Health has the two of you favorable with oral testimony, but that also the department submitted favorable with amendment. Could you explain the amendment?
I would have to get back to you. I'm not sure what the amendment was. We'd have to. Is that for the governor's office of? So we actually followed up with the governor's office on crime prevention, youth and families, and to talk about the changes, because when we submitted this was obviously already in the works before the governor announced that change. And we've clarified that as it is currently written, we are fine with that language, and whatever changes come in the governor's office, they are prepared to move forward as is.
Thank you for the question. We have Delegate Rosenberg.
Thank you, Madam Chair. Mr. Deputy Secretary, you referred to the Cigarette Restitution Fund. First, if you could provide me or the committee the link for that report, or send us the report. And how would you assess the impact that restitution fund has had upon the use of tobacco by citizens in Maryland, particularly by youth who are, whether we're preventing them from getting started on this dangerous path in the first place?
Go ahead.
So Delegate Rosenberg, we will absolutely send that link to you for the Cigarette Restitution Fund report. The CRF funds have been critical in our efforts to reduce both youth use of tobacco products, but also adult use. And we've seen over time that in particular youth use has gone down. The one thing that we have seen that is a blip in that is the availability of e-cigarettes and vaping, right? That has been a new element in the landscape, and we've seen increased use in that format because of the perception that it is less dangerous or less harmful. And so it points to our continued need to be able to do education, outreach to youth particularly, because the vast majority of people who smoke or vape start at a young age.
Sure.
Is that reflected in the report?
I believe so, but I don't want to swear by that, but we can make sure we get you the data on that, which is typically contained in our youth risk behavioral survey.
Excellent. What great questions for the young people today, right? Great bill to sit in. So we have, I saw first Vice Chair Collison and Delegate Shalega.
Thank you, Madam Chair.
I'm assuming that in shifting the responsibilities of, or if it's current practice, then it's already taken care of in terms, there's no diminution of funding and resources for these services for the children. It's just a shifting in responsibility and the other agency it's now in their budget. Is that right?
Correct. There is no change or decrease in services.
Delegate Shalega,
Thank you so much.
my pleasure.
So the budget, is this bill going to talk about all the budget, all the money that was received from the lawsuit about cigarettes and tobacco was paying into the state?
This bill doesn't address that. These are the tobacco 21, the alignment that is just a statutory alignment with federal law and doesn't carry any financial, there's no fiscal note on that piece of it. And then the second piece, which is for the cancer prevention funds to be able to allow funds that are not being used by a county. And we typically make that assessment after the midway through the fiscal year. That county says, we cannot spend these funds. It simply allows us to use those funds in another county that can. So there's no additional funds. It's simply reallocating that.
Thank you, Delegate Shalega, for your question. Delegate Woods.
So I just wanted to piggyback on the whole transfer of unused grant monies.
Mhm.
Can you just give me an idea of what if that's transferred to another county, what are some of the areas that the money is used to fund?
Sure, I'm gonna turn it over to Scrum.
Sure, thank you. So in terms of the areas it'll fund, there will be funds that can be used for diagnosis and testing and different screenings as well as treatment support.
Okay. Any other questions for this panel? Seeing none, I want to thank you both for being here and for providing the testimony. And whatever was asked that you don't have, if you will be so kind and send it to the delegate, but send it also to the whole committee as well, okay?
We will do so.
Thank you. Have a blessed afternoon. We have more witnesses on this bill. We have, and Ms. Crum, please say hello to John Crum. We have next Kathleen Hoke and Blair Enos. Will you be so kind and come up? And those will be our last two witnesses on this bill. Is there, hi, what is your name?
I'm Blair Innes. Kathy Hoke is here, but she's not going to be testifying.
Okay, wonderful. How are you?
I'm great, thank you.
Good, you can get started.
Okay, thank you. Hi, good afternoon. My name is Blair Innes. I am the Deputy Director of the Legal Resource Center for Public Health Policy here today in support of House Bill 42. I specifically wanted to talk about the military exemption portion of the bill, just because that is what impacts the work that we do at the Legal Resource Center the most out of everything discussed in this bill. And so Maryland passed Tobacco 21 before the federal government did. So when we passed it, we had this exemption. Anyone active duty member of the military with ID is able to purchase between the ages of 18 and 20. And that was fine until the federal law was passed and it didn't include that military exemption. And so once the federal law was passed, it became a violation of that law to sell tobacco products to anyone under the age of 21. Without exception. And so you might actually have noticed that Maryland has this signage requirement as well. Once the federal law came out, the Maryland Department of Health was rushing to change the signs to remove any information on the military exemption. So now there are, to my knowledge, no states that are selling tobacco products to anyone under the age of 21, certainly not lawfully. And so this bill is really just a simple way to clarify the law and put Maryland on par with the federal law. So for that reason, I ask for a favorable report on House Bill 42. Thank you.
Thank you. Great testimony and support. Are there any questions for this witness? Seeing none, thank you so much for your time and your testimony. We really appreciate it.
Thank you.
And this actually, colleagues, concludes the bill hearing on House Bill 42. And next, we actually have House Bill 57, Prescription Drug Monitoring Program Dispensers veterinarians. If you can please come up and bring your panel. Thank you very much. Tell us why we need this bill.
Good afternoon again.
Good afternoon again.
And I have with me Anna Lazaridis, who's the director of our prescription drug monitoring program, to provide any
Wonderful. Welcome.
support as needed. Thank you.
1 second. To the students, have a wonderful day. Thank you for being with us, okay? Go ahead.
Thank you. I'm here to discuss House Bill 57, which is to expand reporting requirements for veterinarians for the prescription drug monitoring program. So the vast majority of controlled substances prescribed by providers are dispensed by pharmacies, but a small but meaningful number of prescribers dispense controlled substances directly from their office or clinic to patients to take home with them. And this is to ensure access to those medications. In Maryland, physicians, dentists, podiatrists, nurse midwives, and nurse practitioners who dispense controlled substances are required to report this to the Prescription Drug Monitoring Program, the PDMP. This bill would close the last gap by requiring veterinarians who dispense controlled substances to their patients from their office or clinic to report it to the PDMP. This reporting would be in the same system, format, and frequency as other dispensers in Maryland, which is a minimal reporting burden. And just to be clear, prescriptions for controlled substances can be filled at a pharmacy. The medication can be administered in a clinic to a patient, which means that it is given to them and is not taken home, or lastly, can be dispensed. And we are only talking about dispensing, where somebody walks away with that controlled substance. That is the subject of this bill. Reporting veterinarian controlled substance dispenses is a national PDMP best practice. 17 states in the District of Columbia have enacted legislation to collect this data, and 13 states require daily reporting. In January, the PDMP contacted states with existing veterinarian dispensing reporting mandates, and it was found that 16 states, in addition to the district, enforce these requirements. Maryland's PDMP Advisory Board is required by statute to provide ongoing advice and consultation on the implementation, and the Advisory Board supports veterinarian reporting. The medications dispensed by veterinarians includes opioids, such as hydromorphone, includes benzodiazepines, such as Valium, and these controlled substances need to be registered in the PDMP, as is any other medication that is dispensed or prescribed. As I noted, this bill only impacts veterinarians who are dispensing those medications. If they're administering in their clinic, they do not have to report to the PDMP. And I think the really important piece here is that we have a system where these dispenses can be logged in. It's an online platform, but it is also available in Cornerstone, which is the most widely used electronic health record in veterinarian practices. They have a module built in that could also automate PDMP reporting. So in conclusion, this bill really closes a gap in reporting of controlled substances, and we encourage a favorable report from the committee.
Wonderful. Thank you. And I know you're here for questions, correct?
Correct.
All right. Are there, yes, I see questions. Delegate Hutchinson, followed by Johnson. Thank you, delegates.
Thank you, Madam Chair. I just saw that the Farm Bureau was in opposition to this, and I just, living in the rural area and working with farmers, I'd like to understand your response to that, to their concern. Have you seen that?
As I understand the concern, it's around the burden of this. We don't want there to be a burden, but we want to close the last gap in reporting. As I mentioned, every other prescribing provider who dispenses has to report into the PDMP. And it takes about two to 3 minutes to report this in. As I mentioned with the EHR with Cornerstone, if they have that system, it can be a built-in module, and we've already discussed this with Cornerstone.
You're welcome. Delegate Johnson, followed by Delegate Shalega, followed by Hill.
Thank you, Madam Chair, and thank you for coming with the presentation today. I have a two-part question. I see the letter from Maryland Veterinarian Medical Association. And first it says that the information will be misleading and inaccurate to the state regulators, officials seeking to identify misuse of controlled substance. I'd like to ask your opinion on that. And then does every veterinarian clinic have access to the PDMP?
So Delegate, the first question, I'm not sure why it would be inaccurate, right? The veterinarians themselves are entering or the staff are entering the amount of medication that is dispensed. So it's unclear to me why it would be inaccurate then in that instance.
Animals, not human patients?
That is correct, but the medication is the issue, right?
Right.
So the medication is what we are recording. And then I apologize, the second question,
Every veterinarian clinic have access to the PDMP?
and Anna can talk a little bit about that, yes.
No, the PDMP is only for supervision for human patients. So veterinarians will not have access to the PDMP.
But
They upload to the system, but they don't have access to the data within the system. So those are two different things.
Can upload everything they need.
Yes, they can. There's several ways that that can be done.
And just to follow up, what are the ways that that can be done?
We have a platform called, a platform called RxGov, where the veterinarian can log on and register to that platform and upload the dispenses that way. We are coming in the future of being able to provide an Excel sheet template that they can upload that as well. And then other Cornerstone, which is one of the EHRs that we were discussing earlier, I contacted them and they said that for all of the states that require veterinarian reporting mandates, they create templates for ease in reporting and uploading to the PDMP.
And if I may just follow up on that, it says in the animal policy group letter that no state has added veterinarians to the PMP since the adoption of the system, but the PMP is for humans, correct? Is that the answer? That's the reason why,
so yes, the PDMP is for humans. The
right?
medications that are being administered in by veterinarians, could be diverted to humans. So it creates this path where they cannot see into it, but they do have to put information into the system.
Through what was just explained.
Exactly.
And it's the medication, the amount of medication that matters.
Correct.
All right. I have Delegate Johnson, you just asked your question. Delegate Shalega was next.
Thank you, Madam
My
Chair.
pleasure.
Are veterinarians allowed under the law to prescribe medication to humans?
No, it's not in their scope.
And isn't the PDMP program about human overdoses and drug abuse?
Correct. It's
So
about
if-
monitoring controlled substances.
Right, so if a veterinarian prescribed, which they wouldn't be allowed to, somehow a human received a controlled substance from a veterinarian, wouldn't they be breaking the law?
Yes, that is
It-
correct.
So it's illegal for a veterinarian to prescribe to a human. So and this whole program's about human overdose and drug abuse. So I'm mystified why, if you think a veterinarian is abusing an opioid, you could just use the current law. You don't need them to report.
So I'll start and then I'll turn it over to Anna. The issue here is twofold. One is proper prescription practices, and you're correct. Veterinarians should not. That's correct. And the second is diversion, and that's the other piece of this, and that's why we require anybody who's dispensing to record those dispenses into the PDMP. All pharmacies report into that. And when any practitioner, right, who can prescribe a controlled substance, essentially functions as a pharmacy by dispensing a controlled substance, we ask them to put that information into the PDMP as well, so that we have records of where that medication is and where it's going. And so this, in the same way, you note that it shouldn't go to a human, but that's the whole point of diversion prevention that we're doing, right? Even when a physician prescribes to somebody and then they give it to somebody else or sell it, that's illegal too. And this is how the PDMP allows us to monitor those prescriptions and monitor the quantities that are being prescribed.
I understand your, what you're saying, but human to human diversion is far different. So, you know, you already have the tools in your toolbox because it's illegal for a veterinarian to prescribe or give any controlled substance to a human. So if you think that's going on, why wouldn't you use the laws in your toolbox?
This is how we gain visibility that might be going on. Because right now we have no visibility to what quantity or what medications are being dispensed by veterinarians.
That has the animal, right? Delegate Hill, followed by Delegate Chisholm, followed by Delegate Kaiser.
Okay, thank you. So a couple of questions. I know it's short, but
You get one
try to-
question and maybe in a
and maybe a
follow-up,
follow-up.
okay? And you know I love you.
I know you do. I know you do. And we have a very short number of bills today, but so can you explain how the registering of prescriptions to a central monitoring unit allows you, whether it's through veterinary or human practitioners or whatever, how does that help you track where the drugs are flowing? When you're talking about large animals, how do you not get distracted into looking at the quantity that's going and misassigning it and saying this must be a how does that not, label a practitioner as being out of alignment because it's a large quantity? And how has that worked so far in helping you to track diversion where you have been using it with practitioners of human medicine?
That was a loaded question. Go ahead.
So I'm going to take a few pauses in between answering as well.
Thank you.
The Prescription Drug Monitoring Program has a technical advisory committee that reviews outlier behavior amongst prescribers. So what they do is they review the information, they approve certain algorithms and metrics to monitor prescribing behavior. So everything that we do, that we monitor, goes through our technical advisory committee. And our technical advisory committee is comprised of physicians, dentists, pharmacists, and nurses as well. All of the information that we collect and where we notify prescribers of outlier behavior, all of that is done through the technical advisory committee and is approved through them. So it's not simply looking at, oh, this prescriber has, 100 prescriptions more than this other prescriber in a neighboring county. It's more looking exactly at, I'm sorry, I lost my track of thought there for a second. It's more looking exactly at the behavior and then looking at the outlier positions as well. So for example, a prescriber could be a hospice prescriber. So of course, they're going to be prescribing more. So all of those types of things are taken into consideration. So it's not that we just look at a high volume. It's other things that are taken in consideration. And it's also not done in a vacuum. It's done with the advice of the technical advisory committee. Does that answer your question? Okay.
Okay, so you can go ahead, but I'm going to adjust the rules from last year. Remember how when we have a long day, people have to give us dinner? If we have a short day and you made it a long day, you're gonna have to give us dinner. So go ahead and ask your question.
Fair enough. Insure for everyone. So are you saying that if veterinarians are required to report, they would have a representation on the advisory group and they would be compared to other veterinarians to look at their patterns, not compared to pediatricians or other folks that they're like to like?
as of right now, there is no plan currently to have veterinarians included in any of the monitoring or metrics that we do. The first thing that we wanted to do, according to the advisory board, was to collect the data first, glean the information we can from it, and then take any other next steps, which we don't have any plans right now for that. But it would be a good idea that if it did happen, to include a veterinarian on the technical advisory committee and on the advisory board so that they could be part of those processes as well.
You have the first dinner to provide to the committee. Go ahead.
So,
Chick-fil-A.
so this is about reporting, and you have a mechanism for veterinarians who do not have electronic records to be able to report as well.
If they don't use an EHR, they can go on a computer, sign on to a platform, and be able to upload their dispenses.
The RxGov.
Correct.
Okay.
Correct.
Thank you. All right, Delegate Chisholm.
Thank you, Madam Chair. And I'm gonna make it fast because I'm too poor to buy everybody dinner. But I am gonna refer back to the Animal Policy Group letter that Chairman Penny Melnick referred back to. And you said there's 16 states that are now involved, but there's several states that have come off since joining. And they do make a good point that the PDMP was really put into place to identify and help out with opioid abuse. So my question to you is, do we have any, can you cite any states that have seen an uptick in opioid abuse from veterinarians prescribing these opioids? And what type of opioids do veterinarians have that can be prescribed and abused in some sort of fashion?
So to the first point, the purpose of this is to give us visibility, right? I think one of the challenges we have is that it's hard to say what's happening without seeing the data for it. There has been, and I can share with you the paper around vet dispensing and increases in prescriptions for hydrocodone, which is an opioid and is commonly used as part of a cough medicine. It's actually one of the highest prescribed medications we see that veterinarians prescribe, but it's also, we have no visibility into how often it's dispensed. I don't know the answer to that part of it, right? And then I think the second piece of this is in terms of diversion. You're right, the PDMP was designed to largely on the opioid, but we also look at all of the controlled substances that are being prescribed because a number of them have abuse potentials as well. And so in addition to the hydrocodone, which is most commonly dispensed according to the Veterinarians Association, there are also benzodiazepines like Valium that are also included. I'm just naming one of them that we also want to make sure we have visibility on.
You could have a follow-up.
So in short, you're out looking for a problem that doesn't exist. We don't know if it exists or not. So we're in search of a problem. And when it comes to hydrocodone, why wouldn't they just, you just said that they keep it in stores and why wouldn't they just, if somebody is abusing that, why wouldn't they just go buy it from a store? And I know that we're not monitoring every grocery store or every Walgreens or CVS. They could still, if somebody wants to abuse a drug, they could still go get access to that without going through this elaborate process of having a veterinarian prescribe it to them.
So a medication like that would have to be prescribed. It would have to get it from a pharmacy, and we actually do have visibility of what pharmacies are dispensing, right? And we have taken action when we see pharmacies hit our technical advisory committee as being an outlier. We take action. I think the issue here is we're not really looking for a problem. We want to make sure that we have identified problems that exist, and if they don't, we don't need to reach out to that veterinarian. I assure you, we would be happy to have no outliers and no challenges. That would be the best possible outcome.
You're welcome. Delegate Johnson, you're good? 1 second, I know it was Kaiser, but he had asked me before for a second and I didn't see it on time.
Thank you, Madam Chair. I think maybe you just covered it with Delegate Chisholm's question. So pharmacies prescribe pet medications. So are they all currently reporting? And if not, will they be required to?
Yes, all pharmacies that dispense controlled substances, whether it's for a patient or for an animal, must be reported to the PDMP.
Thank you. And Delegate Kaiser, thank you for your patience.
Thank you, Madam Chair. And I just wanted to follow up as I'm listening to some of my colleagues' questions to make sure I understand. We're not, no one's concerned that a vet is prescribing to humans. It's that a vet is prescribing for the pet and the human is using it. And then you're looking for the outliers. And if I understand the question from Delegate Hill, which will need the Hill exception on short hearing days, Madam Chair.
Yes.
But that Delegate Hill's question is that in looking for outliers, so it's not that someone's buying a lot, but you're looking for outliers the same way our credit card companies know someone has stolen it because suddenly it's being used in different ways and in different places and so forth. And then following up on Delegate Chisholm's question, I think he was asking or if we're searching for a problem, but I think you're indicating that by having this program, and I guess this is my question, that by having this program, you would be able to identify the possibility of a problem because without this, you wouldn't know. Is that correct?
That is correct.
Isn't that
yes.
so? Yes. Thank you, Delegate Hill again. Thank you, Madam Chair.
You're welcome.
That was at least short, though multiple.
It was. And I'm being flexible today because it is a short day, but Hill is not getting off the hook. So we have Delegate Gazzoni followed by Bagnall, and I think Hill is coming back. She's definitely on the hook. Gazzoni, go ahead.
I'm hoping this will be a very straightforward question. And I'm just curious because I understand that some may see this as additional administrative burden. So can you tell us about how many, either a number or percentage of veterinarians in the state are actually dispensing controlled substance directly? Because that's what needs to, based on what I've heard, that's what ends up getting reported, has to be reported, correct? Thank you.
Okay, so we received a survey from the MDVMA, which is the Veterinary Medical Association for Maryland. And we just received this survey, and I believe they have on here, we'll look up the number and they would be able to answer this question as well, that 52% dispense DEA Schedule III substances. And for Schedule II substances, 35% of veterinarians dispense Schedule II substances. And for Schedule IV, it is 60%.
50% mark. How many veterinarians is that?
So they had about five, I'm quoting rough numbers here. They sent this survey to about 2,200 veterinarians. They said they got somewhere between 500 and 600 respondents. And so it's a percentage of those respondents.
I have Delegate Bagnall.
Thank you, Madam Chair, and
pleasure.
thank you for your presentation. I think we've defined the problem. This isn't a solution looking for a problem. The problem is the opioid crisis and trying to wrap our arms around identifying where the access points are. My understanding is that this is a tool in that effort where we could perhaps overlay information. And am I correct that this would only identify prescribing of controlled substances, because there are prescriptions like xylazine that are not actually controlled substances because they don't have a human use, and those would not be part of this program. Is that correct?
That is correct. And this would only identify dispensers. So prescriptions are already covered by the pharmacies.
Yes.
So would this give us a tool where we could look at hot zones or other efforts that we're already making in addressing the opioid crisis and be able to sort of cross-reference?
So we do that with the PDMP currently, right? With all of the prescriber types that I named, and this would color in the map, if you will, of an area that's right now just blank for us.
My pleasure. I have Delegate White.
Thank you, Madam Chair. I guess I'll be the caboose here. So my question
You
is
should correct me. It's not just white anymore.
White Holland, but
Thank you.
thank you, Madam Chair.
Delegate Kaiser's looking out for your husband here. Go ahead.
Thank you. So again, thank you so much for coming in and sharing with us. I wanted to get a sense of the landscape around the country since we have seen testimony where other states have removed this from their and repealed these types of legislative mandates. And so just given the tool that this would the tool and the opportunity to provide this reporting, what have other states seen in this regard as it relates to this larger issue that we're seeing as it relates to the opioid crisis? What have other states witnessed and observed in the reporting where states have implemented this, and what we're looking to also do here?
In terms of other states, what they've seen, I cannot speak to that. But what I can speak to is that it is considered a national best practice, and the Prescription Drug Monitoring Program Training and Technical Assistance Center, along with the National Association of State Controlled Substance Authorities, have written reports on how this should be considered a national best practice for implementing monitoring of controlled substances from veterinarian offices.
You can have a follow-up as well.
If that is the case as a national best practice, then why is it that we're seeing states taking actions to then walk it back?
In terms of the states walking it back, I'm only aware of 2 states that have removed the mandate, and that is West Virginia and Alaska. So those are the 2 that I have. We reached out to the different PDMPs to confirm that their laws were still in place, and from the 17 that we have, those laws are still in place. We did not hear anything that it was removed. And one other thing to think of as well is not all PDMPs are created equal. For example, we have a very strong infrastructure here in Maryland in terms of monitoring and being able to report. And we actually waited and learned lessons from other states in terms of how to roll out this process if we are able to do it, if it becomes mandated.
Good question. Delegate Riley.
Thank you, Madam Chair.
welcome.
Okay, so since the PDMP is actually for human use to figure out, how many humans are actually using this controlled substance, by putting in the veterinarians' data, would this really mess up our data because you're assuming that these are for humans and not for pets? Or is it different when they go into the database? This is saying, this is for a pet.
So according to the ASAP reporting standards, you have to put a species code in when uploading the information. So the species code would be 1 human, 2 pet. So and we also have a way that when you're monitoring the data, we have a little icon of a paw print in there so that a prescriber can easily see that this is for an animal, not a human.
We're so sophisticated. Any other question? Great question, Delegate Riley. Any other questions? Seeing none, thank you for being so patient as we try to understand this bill and address the questions and the concerns of other parties as well. Thank you for all your efforts, okay?
Thank you.
Thank you.
Oh, what is the request? Will you please do that? Contact the 2 states that walked it back, and please let us know the reason, okay?
We can.
Thank you so much. Good point, Delegate Hill. We have next, if I may, we have we have, I think, favor with amendment now, Dr. Ashley Nichols and Dr. Matthew Weeman from the Maryland Veterinary Medical Association. There are 2 witnesses. Will you come forward? Oh, he's virtual. Can you bring him up as well, please? Thank you. Good afternoon. How are you?
Hi, I'm good.
And thank you for being patient, okay?
Oh, that's okay. I do want to add, I'm happy to answer any questions. I have some answers that hopefully will help.
Okay.
Who would you like to go first? Would you like me to go
Yes,
first?
absolutely.
Hi, I am Dr. Ashley Nichols, a small animal veterinarian practicing in the state of Maryland, as well as president of the Maryland Veterinary Medical Association. I'm here speaking on our position of favorable with amendments on HB 57. Please refer to our written testimony and survey for in-depth information on our position. It is important to have 2 amendments in this bill and not wait for regulation. While MDH attests that the burden is minimal, there's still a burden. Not including clear language in the bill will leave the veterinary practitioner with unclear expectations and result in false data. Our First Amendment is reasonable, better use of limited resources. Currently written, practitioners that never dispense still have to log in daily to confirm they still aren't dispensing. A practical option is for these practitioners to file an exemption form attesting they will not dispense. Secondly, an emergency 72-hour exemption is in line with our neighboring states. Data shows veterinarians are minimal dispensers, less than half a percent to begin with. Combined with our survey, the amount of 3-day or less dispenses is a fraction of 0.5%. However, exempting will ensure continuity and access to care of veterinary patients across the state. Despite being recommended as best practices to include veterinarians, 35 states still exempt veterinarians. 11 of 35 had included veterinarians, but had to remove them due to the issues created by having veterinarians in a system that is not designed for them. We at MDVMA recognize the importance of working together to protect public health, and we are not so different from our MDH colleagues in that we believe in ending the opioid abuse and diversion. We have spent time since the last session trying to work with MDH representatives so that we can meet the requirements and minimize the burden it will cause veterinarians. Please amend this bill to exemption for veterinarians to submit reports if they forgo dispensing and a 72-hour exemption for emergency dispensing. Thank you guys very much.
Thank you for practicing in Maryland and for your testimony today. I'm going to open it up for questions now. Actually, let me ask Dr. Matt Weeman, will you be so kind and give us your testimony, and then we'll open it up for questions, okay?
Certainly, thank you. I am Dr. Matt Weeman, a mixed animal veterinarian practicing in multiple counties around the state of Maryland, as well as the Legislative Committee Chair representing the Maryland Veterinary Medical Association. And I also would like to refer the committee to our written testimony, which provides greater detail on our position of favorable with amendments on SB 235. And also the survey data we have available on 2,500 veterinarians in the state regarding dispensed medications. We do need to clarify some of the numbers that you were given from the prior panel. For now, I want to highlight that in spite of the tremendous controversy surrounding PDMP reporting for veterinarians, we did work hard to come to compromise with the Maryland Department of Health over the last year, and I'd like to thank the chair for helping to facilitate those conversations. Ultimately, while there are many reasons we disagree with MDH's proposal to include veterinarians in PDMP, we were at a point of accepting the bill when the Maryland Department of Health had agreed to 2 key provisions: a permanent exemption for veterinarians to submit reports if they forego dispensing, and a 72-hour exemption for emergency dispensing. After the Maryland Department of Health walked back those commitments they had previously made in this session, we've been forced into a position of effective opposition to the bill. Our requests are well in line with our neighboring states. Virginia has a 7-day exemption. Pennsylvania has joined the majority of 35 states who have exempted veterinarians from PDMP altogether. Delaware allows for a 3-day suspension of controlled substances and also exempts veterinarians from the PDMP. As for integration in Cornerstone, I run that practice system. They've told me they won't integrate with PDMP, but I have no reason to not believe Anna on the topic. Regardless, even if Cornerstone will integrate, that's one system. And veterinarians around the state run more than 20 separate platforms that don't integrate. At the end of the day, given the nature of the request, we recognize that this bill is likely to pass, and we're trying to make sure that the veterinarians of our state aren't being forced to spend an excessive amount of time reporting on something that none of the data available seems to support has any merit to the protection of public health or the mitigation of the opioid epidemic plaguing our communities. Thank you.
No, the time stopped, but you were only 2, so I want to let you just give me all your thoughts. Are there any questions? Delegate Shalega.
Thank you, Madam Chair. Thank you both for being here. I guess this is probably for Dr. Nichols. So, would you say veterinarians are small businesses, every one of them?
The vast majority, there are corporate entities, but the veterinarian industry tends to be a small practice.
I'm looking at the fiscal note and they have a impact on small businesses. And the fiscal note says it will have minimal or no impact on small businesses, but you would probably disagree with that.
I would disagree on two forms. One, it is either going to affect how many patients a veterinarian can see in a day, which is already an impact that I'm sure many of you who own pets have seen. It's taken longer to get into your veterinarian. Additionally, if the veterinarian assigns or hires somebody to do the inputting, that's going to be an added expense that either the veterinarian is going to have to eat or pass on to the pet owner.
Madam Chairman, thank you for your time here today. Could you, you had mentioned that you'd like to respond to some things, and when your opening remarks, if you have some clarification on any of the questions that have been asked to the prior folks testifying, I'd like to invite you to do so.
Great, thank you. So one thing is we did, and I hope you guys got the survey. If it wasn't uploaded, because we literally finalized it yesterday, we will make sure you all get the survey results. But based off of our survey, it is 91% of veterinarians are actually administering or giving the medications in the hospital. And the 66% are dispensing. So that's sending the medications home with the owner, but that varies for the drugs that are being dispensed, what type of drugs and things like that. It shows for the 3-day or less, what we were finding is the vast majority of medications are either being sent long-term as chronic medications for patients that need it, or is being longer than 3 days. So the amount that is being dispensed that's why I said it's a fraction of that half, like 0.34% is what is actually being dispensed by veterinarians. And the dispensation under 3 days is a fraction of that 0.34%.
Well, and I think what Dr. Nichols is attempting to state is.
So we usually don't allow that, but I'm going to go ahead and allow it, okay? Because we do one person at a time, but go ahead. Go ahead.
Okay, I'm sorry. I didn't want
It's
to
okay.
step out.
You don't know you were not here for the rules, so that's okay. Go ahead.
The 0.34%, just to further clarify, I think is referencing data nationwide on prescriptions, and that veterinarians are prescribing 0.34% of total opioid or controlled substance rather prescriptions nationwide. And this would be information already coming from pharmacies where the reporting is available. And in my testimony, when I had said I wanted to give some clarity, it's 27% of veterinarians that we have in our survey that were dispensing Schedule 2. And it's 56% that dispense Schedule 3, and about 56% that dispense Schedule 4. So our numbers are actually slightly higher for Schedule 3 and 4 than Anna reported, and lower for Schedule 2. The reason we think that's important, Schedule 2 are your high abuse drugs, or your drugs most likely to be diverted and misused if that's a concern. But only 27% of the veterinarians responding to the survey dispense any of that medication. And well, that was the question, so that's what I'll answer. I don't think I was given an invite to keep going.
Yes.
Just to clarify, does that mean then that 99.66% of the medications that we would be concerned about are being filled through pharmacy, and only 0.34% are being dispensed at the veterinarian's office?
So no, my understanding is that the 99.6% of all opioids is prescribed or dispensed from either a pharmacy, a human doctor's office. So veterinarian opioid dispensation is less than 1%. So it would be 99.6% of all other opioids.
You're welcome. I have Delegate Johnson.
Thank you, Madam Chair. And this
My
question is
pleasure.
for Dr. Nichols. Do the veterinarian clinics currently keep track or log the medications that they do dispense? And if so, why would it take so much extra time? And you talked about extra personnel to input this information if it's such a small amount.
So because the systems are not integrated, I currently use a system because I work a corporate practice and that is online and things like that. But you'd have to separately take that information from like John Doe Fluffy and take that information and put it in. Additionally, that information is not saved to where we can access it every 30 days. So one of the most common medications in my practice that we dispense is phenobarbital, which is a seizure medication. That is something that we dispense every 30 days, or in my case, I prescribe, because the burden falls on me to measure the medications, to count the medications out, to log the medications, verify, because when DEA comes in, they're looking at me, they're not looking at anybody else. And so we log our own stuff, but then we'd have to take that information and separately put that into the PDMP information. And they don't save any of the data in the PDMP system. So we'd have to re-enter the same information every 30 days for this same patient who hopefully, if we're doing our job right, is living a very long time.
You're welcome. Delegate Chisholm.
Thank you, Madam Chair. And just a matter of confirmation, you said that you had the amendments basically were adopted by the Maryland Department of Health last session, but this year they were not. Is that correct?
Yes, if I can answer that, I don't want to be breaking the rules again. I couldn't hear the whole. Yes, so we had an agreement that we were going to be given a 72-hour exemption. We had asked for longer. We'd asked for 7 days. We ultimately agreed, okay,
May
7
I
days.
ask you something, Dr. Weeman? Can you please come a little closer to the microphone? It's a little bit difficult to hear you.
Is this better?
No, can you speak maybe a little louder?
So we were originally given an exemption of 72 hours. We had requested longer, and we agreed to go with the 72-hour exemption. Our reasoning for that request was veterinarians, particularly in rural areas, need to be able to see emergencies. We don't have emergency infrastructure that's available to our human colleagues, and being able to administer pain medication quickly on a holiday or a weekend or other time like that tends to be pretty critical to our patients and to our client needs for taking care of their animals. The other exemption we had requested was just a permanent exemption altogether if veterinarians forego dispensing, and we felt that made a significant amount of sense. If the goal is to avoid diversion, just have veterinarians stop, if they're willing, just stop dispensing altogether. And there is a way that we could continue to have a 3-day exemption and no PDMP reporting, and Delaware does that. Delaware specifically limits veterinarians to 3-day dispensation. They can get through an emergency critical period and then prescribe from there, and it would be in the PDMP database. What we're asking is we disagree with MDH that this is not a significant reporting burden for our veterinarians. So we're asking, let us out of it and let us work out a way that we can prevent diversion, and veterinarians can forego dispensing altogether, with the exception of a 3-day emergency de minimis amount. And I know there's questions about that, but 3 days for an animal it's impractical to assume somebody's going to be able to drug shop effectively, cost effectively at a veterinarian we've seen legislation through the House reflecting the fact that we're overworked and busy, and there's concern we're not able to deliver for, Maryland citizens efficient care. It's too hard to get into a hospital to get 3 days supply reliably to garner street value. And you're going to exceed the cost of that medication trying to get a 3-day street value drug from a veterinarian repeatedly. And so we just think that there's a better way. Keep veterinarians out of this system meant for humans. Multiple states have walked it back, and ultimately just we can avoid diversion altogether as well and still give MDH the data they need.
Any other questions? Seeing none, I have a proposal. Dr. Weeman, will you be so kind, and one second, Nichols, I'm having a senior moment. I apologize. You're right in front of me. Dr. Nichols and Dr. Weeman, will you be so kind and meet with the Maryland Department of Health? Can you please make sure that you meet and
Again,
talk?
yes.
All right. Yeah, absolutely. And this is session, so the meeting is very different. So I need you to sit down and meet and discuss. I am particularly interested in knowing what other states are doing, right? What other states that, and I'm also interested in the Delaware approach, right? And also Dr. Weeman's proposal, and see where you can. I understand the need to track this because we do have every year more than 2,100 people that lose their lives to the opioid crisis. We know that this is for the owner of that pet that has access to the medication. That is the intention. We know that you are small businesses and we don't want you to suffer. I know I have a pet and it takes a while to get in as well. So can we discuss and see how we can compromise and work together, right? To make sure we lessen the burden on you, but that the state who has to track this can also do their job. Will you be so kind and meet? And who will take the initiative?
So I will, because that has been our goal all along. That's why we've been trying to meet since last session and this session. So
Okay.
I can work together with my executive director to reach out and set up a meeting.
And will you give me a second?
Mhm.
From the Department of Health, right now, they're the last witnesses because the other positions are written. Will you please go outside and talk and figure it out and exchange numbers? All right? Thank you. Fantastic. And the committee thanks you.
Thank you so
Okay,
much.
and if this goes to subcommittee, once you talk, I'd like you to both to come to the subcommittee. Okay, you're invited.
Okay.
All right,
Thank you.
which are virtual and it will be easy.
Okay, thank you.
Seeing no other questions, I want to thank you both and I'm so glad that we took the time. This is fascinating to digest it and to really look into it, because there's always two sides. Sometimes my grandmother would say 3 sides to a story. So thank you very much for being here and for coming. And colleagues, this actually concludes the bill hearing on House Bill 57. Now we have House Bill 127, which is the Public Health Non-Occupational Post-Exposure Prophylaxis Standing Order Program. And would the department come up, please? And can you bring your panel? Thank you. And they're going outside? Wonderful. All right. Good afternoon again.
Thank you again. I have with me here Dr. Peter DiMartino, who is the Director of our Infectious Diseases Prevention and Health Services Bureau, to help answer any questions and provide his perspective as well. We're here to talk about House Bill 127, which is to allow pharmacists to prescribe non-occupational post-exposure prophylaxis. So since the beginning of the AIDS crisis in the 80s, Maryland has led the nation in responding to the evolving needs of our constituents living with, affected by, or at risk of acquiring HIV. From our clinical centers of excellence that predate the federal Rhine-wide program to our robust community partnerships. Today, 70% of new HIV diagnoses are in Black individuals, 17% in Hispanic individuals, And this bill provides our state with another tool to end the HIV epidemic in Maryland and advance health equity. So non-occupational post-exposure HIV prophylaxis, NPEP, is the use of antiretroviral drugs after a single high-risk event to stop HIV seroconversion in individuals. NPEP has to be started as soon as possible to be effective and always within 72 hours of the possible exposure, and each hour of delay decreases its effectiveness. This bill would establish the NPEP Standing Order Program to be administered by the department, and it will allow pharmacists through a standing order to provide NPEP, which will increase access to care. The protocol that they'd follow would have stringent guidelines and protocols to ensure safety. This bill really provides another route for people who experience delays in care through other mechanisms such as primary care, urgent care, or emergency rooms. This is just another door of entry. Critically, as part of the program, the department will provide direct field services to address follow-up, adherence monitoring, and care engagement needs of participants. And this ensures continuity of care and engagement in care, both during and following the NPEP usage. Of note, MDH understands that the Board of Pharmacy is requesting a clarifying amendment related to which specific staff in these organizations can provide NPEP, and MDH is amenable to these amendments. I thank you for your time, and I'm going to turn it over to Dr. DiMartino.
Questions. Mostly just here to make sure that we can answer any of your technical questions.
Wonderful. So I'm going to open it up for questions. Thank you for coming. I see Delegate Hill.
Thank you very much, Mr. Secretary, and thank you for the program. I'm a little confused. I understand the program shall authorize a pharmacist to dispense under standing order. I'm not quite sure I understand authorized a healthcare provider to prescribe under a standing order. They can write their own orders. Why do they need a standing order to prescribe? I'm confused about that.
So broadly, including healthcare providers that wouldn't normally prescribe. So this is how we allow pharmacists to participate, is initially what we were intending with this, so that the standing order would cover other healthcare providers as well. So we were really trying to go broad-based to ensure that we are creating access points, as many access points as possible for the dispensing of NPEP, was the initial thought.
Sure. Thank you. I guess the thing is that a healthcare provider is someone who's a prescriber, so they don't need a standing order. They're saying it is the order. So I understand the pharmacist, but maybe we can talk outside. I'm just confused about what providers you're thinking of that would need to have an order, a standing order from the state to tell them to prescribe what they would just prescribe by saying, I'm prescribing it, or dispense it by simply saying, I'm dispensing it.
Yep, thank you for that. Well, what we were working towards is not all healthcare providers are prescribers. Yep.
Good question. Delegate Taveras.
Thank you, Madam Chair. Hi, how are you? I just wanted to make sure, I don't know if you were able to have seen or read Medicai's position on this. They are the only ones that seem to be unfavorable. They are saying that this is an issue where they may need, or a patient may need tracking, and they need blood work associated with the prescription of this medication. And just to make sure that there aren't any conflicts, with the medication, with anything else that anybody else is taking, et cetera. So I don't know. Can you help address some of the concerns raised by the Medcai position?
Absolutely. So currently there are 17 states that have allowed for broad dispensing or pharmacists actually having rights to prescribe biomedical intervention. So the actual drugs that people living with HIV take rather than for treatment, but for prevention. So we've been very cautiously and carefully watching those programs. We've also talked very closely with people living with, affected by, and at risk for HIV to make sure that we understand their needs. We've also had lots of conversations with lots of pharmacists. So this program is actually not including pre-exposure prophylaxis very intentionally, because we understand that that needs to be delivered in a medical home with a more intimate relationship with a healthcare provider. We're also acknowledging the fact that retail pharmacy has significant workflow and practice management that we don't want to impede by allowing this access. We've designed this program specifically for Maryland so that we are creating this window that gives individuals who need this service in an emergency situation another place to go. We know pharmacists are well understood in their role in the community. We know that they have a very strong background in both medication management and patient counseling. And the critical piece that we as the department add is that disease investigation that we normally do after someone is identified as living with HIV. We can now provide when an individual is receiving NPEP. So we will be creating both a rigorous protocol to ensure that any contraindications for the medication and the individuals are included in that protocol before the NPEP is dispensed. And then we as the department will be providing that follow-up to make sure that they are getting into medical care as quickly as possible, so that lab work will be done, so that they will then have a more responsive connection to care that they might not have had before going to the pharmacist for NPEP. Sure.
You can have a quick follow-up question.
So just making sure, so you're saying to address or to avoid multiple, you have a system that you're putting the person in place to avoid an individual going in and going to a patient going to multiple pharmacies so that there isn't a level of abuse.
No. So that the contraindication, so that individuals receiving medications that may need additional follow-up, we are going to provide that connection to care through the department. So that's not being left to the pharmacist to make sure that lab work is done, that they actually have a connection to a primary care provider.
Avoid abuse.
Oh, well, we'll be monitoring. So all of the pharmacists will have to register and be part of the protocol. So they will be reporting use of NPEP and how much NPEP is dispensed and referring individuals. So we'll be monitoring from our level.
Thank you. Deli Martinez.
Thank you, Madam Chair. Just for the sake of the committee, could you give an example of when someone would be seeking PEP? I think a lot of folks might not be clear on how this medication is actually administered or used in the real world.
Sure. So occupational post-exposure prophylaxis is relatively well known in the healthcare community. Needle sticks. Needle sticks also happen in real life. I know lots of folks living with HIV who are also diabetic whose partners get a needle stick. There are also frontline contraceptive or prophylaxis that doesn't always work appropriately or correctly. So the condom broke is quite frankly what we're thinking most often will be the situation. We also know that not everyone vets their partners as well as we would all like. So there's definitely those instances where you're suddenly thinking about an interaction and that the risk might have been more than you expected it to be. We also do know that there are moments when there is sharing of equipment for drug use. And there are times when even if you know someone's HIV status, you may not be the one who uses the equipment first if you're sharing. So there are absolutely those moments where it is very difficult to get to an emergency room You might find that the providers there are not familiar with NPEP. And so what we're really hoping for here is many of us have relationships with our community pharmacists. Our community pharmacists are generally open late. And those pharmacists who are in parts of Maryland that are unfortunately more impacted by HIV, we think will be very open to this because they know they are serving their community. In this case, it's a one-time emergency over 28 days that we at the department will support the monitoring and adherence, the additional lab works, the ensuring against contraindications. So we really do feel like this is another way to get our constituents what they need and then also create those linkages to care that are more responsive to keep them out of those situations in the first place.
Thank you. Great question. I have Delegate Olston, followed by Vice Chair Collison, followed by Delegate White Holland.
Thank you, Madam Chair. Just listening to this way, back here. How you doing?
Thank you.
Listening to the list that you just provided, would this also be appropriate for victims of sexual assault?
It will. So we do have a program that we will, I believe, is putting forward an amendment, Sarah. And this provides another opportunity where, again, if you have a relationship with a community pharmacist, you can be in a situation where you then don't have to travel to an ER. So yes, I believe there is an amendment coming.
Thank you. Vice Chair Collison.
Thank you, Madam Chair. I'm gonna use Delegate Hill's approach here. How do we, so it's essentially two easy questions, I think.
You're gonna join her in paying for the dinner for keeping us
Shall we
late?
talk,
Go ahead.
Terry? How will the monitoring work? So I'm thinking about someone who engages in risky behavior, goes to their neighborhood pharmacist, gets the product, the NPEP, and 2 weeks later does the same thing. And so what's to prevent that? That's number one. Number two, I appreciate the efforts to reference and get folks into the appropriate provider who can help them stop the risky behavior or be more cognizant or aware of it. Can you elaborate a little bit on how you would do that?
Sure. So the pharmacist would go through the protocol, check for contraindications, and also check to make sure that they are a good candidate for NPEP. So that 72-hour window is critical. And the shorter the time between the potential exposure and the actual getting the drugs into bodies happens is better. So we want to make sure that the pharmacist is able to dispense, but only pharmacists who are registered with the program and who are using the protocol will be able to dispense. Individuals accepting the NPEP will be referred to the department. So they will sign a release to share their information with us. We will have a part of our rapid response. I think many of you know we have a very active response system in Maryland. We have 56 disease intervention specialists across the state who are generally working with individuals after an HIV infection or after they've been diagnosed with an STI. So it's that team who have that expertise to do that linkage to care. The protocol reads that there will be less than a 24-hour window between the NPEP being dispensed and the referral taking place with our DIS, with our disease investigation specialists. So they will be doing that linkage to care almost immediately. And that's really because we want to make sure that that follow-up is happening for contraindication reasons, for clinical reasons, but it's also really critical that we understand this was a one-time risk, or was it? And if it wasn't, we want to make sure that you have a medical home. And so that if your risk is going to be ongoing, we're going to move you to potentially pre-exposure prophylaxis, which would mean the same medications, pretty much, but on an ongoing basis through your season of risk. So while you are going to be potentially exposed to HIV, we want to make sure that you're taking this medication on a regular basis, but that's different than NPEP. They call that PrEP. So that's part of what we would do. But we also just want to make sure that people have a provider they're comfortable with, who is responsive to them, so that we really are making sure they're getting their wellness needs met. So this is really an entry program to wellness.
Thank you. And thank you for being so patient as we ask these questions, right? And understand the bill. So I have Delegate White Holland, then Delegate Bagnall, then Delegate Lewis, and then Delegate Martinez. Delegate Hill as well. Go ahead.
Thank you, Madam Chair. And Delegate Cullison actually asked one of my questions, but as a follow-up to that, I just would like to know, and given that this is this would be a part of the existing rapid response protocols that you just outlined so eloquently. Could you describe, given the very short window of time to make sure that there's the appropriate linkages to care and care coordination, can you describe the type of internal checks and safeguards to ensure that that happens? Is this something that is already existing within this rapid response model, or is this program that we're looking to create here would create those additional checks and mechanisms?
Thank you for that question. So it definitely builds upon the existing system that we use for HIV, syphilis, gonorrhea, chlamydia. So we have a very robust, very mature data system that is built around this rapid response and this linkage to care. So we're building on decades of experience, really ensuring we have those checks and balances. And in this case, because it is this critical window of making sure that folks are getting into that clinical referral, we're going to double down on those.
You can have a follow-up.
Just very quickly, what does that success look like? And can you provide us with some of that information? Because if this is going to build upon it, it would, if anything, indicate what type of success we could potentially see here with this program.
I can definitely share that data with you. There's going to be one critical difference in this. With the programs that we do around disease monitoring, that's reportable diseases, and we're following up with individuals who might not want us to follow up with them. With this program, folks are going to be standing up and saying, I want this, right? I want this prophylaxis. I want to make sure I'm not going to get HIV from one encounter, one mistake. And they're going to understand that they will be referred to clinical services. So we think our success rate is going to be much better than when we're knocking on people's doors.
You're welcome. I have next Delegate Bagnall, followed by Delegate Lewis.
Thank you very much, Madam Chair, and thank you for this presentation. I'm sort of following on Delegate White Holland, but if you could just frame out for us a little bit, because we are, this is part of our public health effort, the cost of a 28-day protocol versus the cost of maintenance medication for HIV/AIDS in the as our lifespans are expanding with the maintenance care.
Yeah, as we live longer with HIV, and that is a very real thing, which many of us did not think we would be in this place. I'm going to give you a very ballpark figure. So the medication is about $3,600 a month. So this would be a 28-day course once. This proposal does not address payer. We understand that we have a unit at the state that supports survivors of sexual assault. So we know that that portion of population is covered. We are including in the protocol all of the patient assistance programs from the pharmaceutical companies, which quite honestly is how most people pay for NPEP when they can get it. 28 days of medication saves a lifetime of complications of what is essentially an inflammatory disease that makes us age faster and have multiple impacts to our lives overall. For those of us living with HIV, there are constant daily reminders of it. And quite honestly, 30 years ago, I wish there had been a pharmacist who had NPEP to hand me after a condom broke.
And thank you again for being so patient as you address our questions. We're almost done. So, and those of you that are waiting, thank you for being patient. We have next Delegate Lewis, followed by Delegate Martinez, and the last question, I believe, is Delegate Hill.
Thank you, Madam Chair. Thank you both for your testimony for this bill. I want to make sure I understand, because maybe I'm slow, but I didn't hear it when Delegate Holland asked her question. How will the warm handoff between the pharmacist dispensing NPEP and the person receiving it actually take place? Does the health department provide a list of referral points? Will the pharmacist report the number of referrals they made that month to where? How will we know that those receiving NPEP from a pharmacist get the referral and ultimately the help they need? Maybe I missed it, forgive me.
No.
Thank you.
And I can be very, very clear. During the Mpox, formerly known as monkeypox crisis, we had a cell phone. That cell phone got passed around our office every day for whoever was covering that cell phone. That's the cell phone we're going to use for this protocol. So that when a pharmacist dispenses as part of the protocol, they will call or text that number and let us know that they are submitting patient information that has received NPEP. So we will have essentially a field services officer on call for this program. The documentation will happen through our data collection system. So it'll be a modified disease reporting form, but that actual alert for there's something waiting for you, you need to act, that's essentially going to be our on-call. Sure.
Thank you. Delegate Martinez.
Thank you, Madam Chair. Thank you for inviting us in and sharing your story. My question, I think you kind of touched on it with Delegate Bagnall's response to her question, but once you've made the referral and someone is now in the program, and let's say the PEP saved them from that risky situation, but now they're getting on PrEP, are there a cost to the individual for being referred that they take on personally, or how does that work once they're programmatically within the department?
So programmatically, pre-exposure prophylaxis is currently being supported as an independent program at several local health departments across the state. There are some jurisdictions that actually have either federally or locally supported pre-exposure prophylaxis programs. And actually some of our federally qualified health centers, our community health centers, are receiving direct federal funding from the Ending the HIV Epidemic Initiative, very specifically to support PrEP. There is a federal program that supports PrEP directly, similar to a patient assistance program. So PrEP programs are available. Part of this, though, is we really want to make sure that we are addressing wellness, that we are addressing the vital conditions of these individuals, to talk about what is creating risk in their lives, whether that's housing, transportation, education, what those needs are. So it really is about addressing the vital conditions of wellness and understanding that HIV prevention is a way to bring them into that wellness journey, if you will. So PrEP is a tool in that, not the ultimate goal. The ultimate goal is really to create less risk in a person's life overall.
And the last question for this panel is Delegate Hill.
Thank you, Madam Chair, and thank you again. How is this program, as you envision it, different from simply expanding the current program for preventing HIV and rape victims to encompass more people? And what happens to the people who come to the pharmacist, get plugged in, but then never follow up? Are they not going to get the full month? Are they prescribed the full month? What happens to those people? And how is this different from expanding the program for rape victims?
So let me answer the dispensing first. So there are some of the jurisdictions that have expanded access to either PrEP or NPEP where they do starter packs. So there's a lot of event-based, particularly in the LGBTIQ plus community, where they'll do like starter pack PrEP or starter pack NPEP. We decided very clearly to not do that. We want to make sure all 28 days are delivered at the same time. And we want to make sure that we're providing that follow-up from the department's perspective. So this is the full course of medication, tracking who it's going to, providing that collaborative support from that perspective. We did not want to expand Saru's program around sexual assault. While this creates a new avenue for participants in that program to get NPEP at a pharmacy, we wanted to ensure that we were being broader from the perspective of not focusing on any one population. So the question around what are some of those events, that's really not for us to create separate pathways. We wanted to create an open pathway for whatever those events are in an individual's life that they could go to participating pharmacists. Yeah, sure.
Thank you. I don't see any other questions for this panel. We do have 5 more witnesses, and what I want to do is the following. I know Senator Muse has been waiting patiently, and his is really fast. So I'm going to call his bill. If we're done with this panel, I want to thank you for your patience and for explaining everything. If you will be so kind, you may want to just sit and wait and hear the other side as well, and we will be right with the next witnesses, okay? So I'm going to put this one on hold for a second. 5 witnesses left. We'll come back to it. We will now call House Bill 358, which is the Prince George's County delegation, the Prince George's County Work Group on Health and Wellness, PG 4924. Good afternoon, Senator Muse.
Very much, and thank you for allowing me, and for those witnesses who are waiting, thank you all as well. They just called me to come over to finance, so this will be
absolutely
very quick. But again, good afternoon, Chair and Vice Chair, both of this committee and all the members that are here. I guess about 1994, I was first elected to the House. We didn't have all this stuff over here. Most of you weren't born yet. And so it was a tough day in the House back then. But I'm grateful and always happy to come over and to the House. This bill, very quickly, I'm not going to testify. I'll just say a few words and then I'll turn it over to my legislative director. It's a bill that's been before you last year. And when I introduced the bill last year, it was important to me then, but then something happened since last year, which makes me want to push it even more. Sunny night, this is a health and wellness bill, and you have it in front of you. It would establish a Prince George's County Health and Welfare Wellness Group, she'll explain why. But Sunny night, I wasn't feeling that well, and we dismissed at 12. And 3 a.m. that morning, I had a heart attack, and it put me out of commission for 8 months. I never thought that I would see a day when I couldn't preach for 8 months. And so when I got back, I preached for them for 2 weeks before they could go home. But, and all else, and it became important to me in a different way that the health of our children, what we feed them in school, the health of our workers, what we do in government buildings, how do we start this in low income areas? And so that's what this bill is about. I'm going to turn it over. Brandy Calhoun has been our chief of staff. She's almost as old as I am because she came in with me in 1994 and has been a part of the staff ever since. She has gone on since then in terms of health, went back to school and back to class to become educated in that area, and also having a bachelor's and a master's from Frostburg University. She's a tremendous help, and this is very important to her. And this is actually, Madam Chair, her bill. And so I'm going to ask her to please present it. And I thank you kindly for that.
No, thank you for sharing your story. We really appreciate it. I know that we voted in delegation last Friday, and there's a delegation letter in the file.
Yes.
Good afternoon and welcome.
Thank you so much. Thank you, Senator Muse, and thank you, Chair and Vice Chair and members of the HGO Committee. As many of you know, as it relates to the health and wellness of our state, and in particular, Prince George's County, our focus has always been on disease management, specifically in the Black and Brown communities. Therefore, HB 358 will require the work group to review. You can see all the different things, but the most important is the available options for integrative health and wellness programs in the county, and to also review programs that promote healthy eating within the county's government agencies. Just like now we have Sprout in the State House, that's a healthy option that we now have, and that's something we should have in Prince George's County as well. And after reviewing these programs, the work group will be tasked with making recommendations regarding the best practices in health and wellness in the community. And you can see the bill, all the different strategies and programs that the work group will look at. The work group will also make recommendations for incentives that may be provided to employers who promote health and wellness strategies. Further, the work group will review, report, and evaluate the benefits and feasibility of integrative health and creating integrative health and wellness hubs in Prince George's County. In closing, I want to stress the importance of the integrative health component of this work group. Integrative medicine combines the most well-researched conventional medicine with the most well-researched evidence-based complementary therapies to achieve the appropriate care for each person. And just like Senator Muse just said, gave his testimony about him having a heart attack at the sign he died, right after sign he died. In the last 8 months, he has incorporated the integrative health components, not just something he does one day or the next day, but it's a lifestyle change. And because of that, he's able to walk around and do more things. He's back working out, and it's a blessing. Therefore, incorporating integrative wellness into your life and my life and our entire healthcare system's life is a vital importance. And if we want to compete with the top healthcare systems across the world, this is a must. Let's look at the Cleveland Clinic, which I'm sure many of you know about. It's ranked the #2 top hospital in the world, again, for the 2023 by Newsweek's World's Best Hospital. And this hospital system not only incorporates integrative health and wellness, but they have an entire center dedicated to integrative medicine. In closing, Senator Muse does not know all the answers, but what we do know is that we have a health crisis in Prince George's County. Out of the 145 certified outpatient dialysis facilities in Maryland, Prince George's County has 34 of them. That's nearly 1/4 of the dialysis centers. And Baltimore City is right behind us with 27. So the two predominantly Black and Brown jurisdictions have 42% of those centers. This is just one example. There are many more, but I know we must do something to turn our health crisis around. And this work group will be tasked in doing that. Lastly, like I said, I'm just glad to see that now our state has an option of having Sprout here, just to offer healthy options. And that's something we also need in our government agencies too in Prince George's County. Thank you so much, Chairwoman, for letting us go quickly. Appreciate everyone. Thank you.
Thank you again. I urge a favorable report, and thank you for all the work that you've done on it this year, and all the letters will be forthcoming.
Absolutely. Are there any questions for this panel from anyone? I don't see any. The only thing that we need, we have the letter from the delegation. It's in the file. If you could, since it has a fiscal note of 120,000, can you get a letter?
I just talked with the county executive about
Yes.
10 minutes before coming in, and she said the letter will be over by the end of the day.
Fantastic. And it will go to the subcommittee of the Public Health Subcommittee. So if you can make yourself available, if there are any questions, that will be great. Thank you so much.
right.
Really appreciate
Thank
you.
Good day to all of you, and
Thank
thank you
you.
much.
We do have a virtual witness on this bill. Can you call the virtual witness, please? And it is the Maryland Park, I think Park and Planning. Is she on? That will be great.
Good afternoon. Can you hear me?
Good day to all of you and
Thank
thank you
you.
much.
We do have a virtual witness. On this,
Okay.
call the virtual witness, please. And it is the the Maryland Park, I think Park and Planning.
Yes,
Is she on?
yes. Can you hear me?
Great. Good afternoon. Can you hear me?
Yes, I
Can
can.
you? Yes.
Thank
We
you.
have a virtual witness.
Can you turn off your volume? I think you're the one that is repeating.
Competing. Okay,
Oh, because you have the YouTube on live. Can you turn it off?
it's all. Can you hear
Okay,
me
thank
better
you.
now?
Yes, it's better.
Hi,
How are
Madam
you?
Chair, Vice Chair. How are you all doing this afternoon?
We're doing well. Thank
Thank
you.
you for having me. I'll be very quick. My name is Jordan Balcom Colbert. I'm the Government Affairs Liaison in the Office of General Counsel at the Park and Planning Commission. And our board has voted to support this bill with amendments. And we also have written testimony for the record. We talked and reached out to the sponsor who is putting in a sponsor amendment to add the Parks and Recreation Department, which is a longtime supporter of health and wellness in Prince George's County on behalf of the residents. And so we appreciate the sponsor for that. In short, the commission promotes healthy eating, physical activity, and instilling habits for optimum health is one of our top priorities. So this friendly amendment to include us is most appreciated, and we look forward to working with this senator and the community moving forward on this bill. Thank you for your time.
Thank you for your time today. We really appreciate your opinion. Are there any questions for this witness? Seeing none, I want to thank you for your patience because you waited a while. This actually concludes the bill hearing on House Bill 358. Oh, I'm sorry. Are you here? Yes, go ahead. I know, go ahead. And I'm glad that you jumped.
Good afternoon, Madam Chair, Vice Chair, members of the committee. My name is Lorenzo Bellamy with Bellamy Gin Group, and I'm here on behalf of the Prince George's County Council in support of this bill, House Bill 358. You heard Ms. Calhoun really describe the legislation, and so I'm just really here to say thank you to the delegation for passing it out. Look forward to working with this committee and the subcommittee to get this legislation through. It passed out of the Senate, and hope that we can get it through the House this session. So thank you very much.
And thank you for speaking up. Are there any questions for Mr. Bellamy? Thank you very much for being here with us.
It's good seeing
And
you.
now
Thank
this
you.
really concludes the bill hearing on House Bill 358. So we're going to go back to the last bill that we have, which is 127, and we are going to call favorable with amendment panel, which is M. Casa and the Maryland Hospital Association. Are you here? If you both can come up and introduce yourself. And you're favorable with amendment. Delia Collison.
Good afternoon. I'm Laura Jessic with MCASA.
Wonderful.
I'm Jean Krinky with the Maryland Hospital Association.
And who will start?
I'll start.
Okay,
Good
wonderful.
to see you all. So good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Jean Krinky. I'm a senior analyst at the Maryland Hospital Association, and I'm here on behalf of our member hospitals in support of this bill with a friendly amendment. So back in 2022, the General Assembly passed legislation, as you heard, to create a program to provide access to HIV prophylaxis to survivors of sexual assault and child sexual abuse. Since beginning this pilot, the program has removed a lot of historical barriers that have kept survivors from accessing the medication, which is critical because of the time period you need to take it in order to be effective. So our amendments just simply want to acknowledge that the program exists, ensure hospital pharmacies can continue providing the medication, and also ensure that the patients aren't billed in error. So our amendments are included in the testimony, again, just to reflect the program and provide education on it. And we're happy to work with the department on implementation just to ensure that the workflows the hospitals have developed aren't impacted negatively. And we ask for a favorable report with the amendments. Thank you.
Thank you. Go ahead.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Laura Jessic, the Sexual Assault Kit Initiative and Response Team Manager at the Maryland Coalition Against Sexual Assault. I'm here at the invitation of our director, Lisa Jordan. MCASA is the coalition of the rape crisis centers across the state of Maryland, and our office includes the Sexual Assault Legal Institute, where we provide direct representation to survivors of sexual assault in Maryland. We're here in support of House Bill 127 with amendments that acknowledge, like Jane said, the existence of the program for preventing HIV infection for rape victims and allows providers to continue utilizing this program for sexual assault and rape survivors. For sexual assault survivors, contraction of HIV is a major concern. In fact, 91.9% of rape survivors reported fear and concern for contracting HIV. In response to this, the program for preventing HIV infection for rape victims was created. This program, which is administered by the Governor's Office of Crime Prevention and Policy Sexual Assault Reimbursement Unit, resulted in the creation of a streamlined process for prescribing sexual assault survivors with NPEP medication that ensures timely access in a timely manner by providing the medication at the time of discharge or through arranging courier services with a mail order pharmacy contracted with the state. The program also addresses the appropriate screening for NPEP medication at the time of the exam and follow-up care. To conclude, MCASA supports HB 127 with the amendments that allow qualified healthcare providers to continue utilizing the already established program, which, according to the data provided by the Sexual Assault Reimbursement Unit, has provided 505 survivors with this medication between October 1st, 2019 and September 30th, 2022. We look forward to continue working with the Maryland Department of Health and Maryland Hospital Association on this issue. For these reasons, we request a favorable report with amendments.
Thank you very much. Are there questions for this panel? Okay. Seeing none, thank you both for your patience and sticking around to be able to testify. We appreciate your time. At this point, we're going to move to an unfavorable. I'm going to do virtual favorables before unfavorable. But yeah. Okay. Oh, okay. So go ahead, Ms. Casemeyer. We're going to do an unfavorable panel, and then we're going to go back to virtual. Good afternoon.
Good afternoon. Hello, everyone. And I know I'm about between you and your end of your afternoon, so you'll be glad I only have 2 minutes. But this is a awkward opposition position to be in, and MedChi recognized that. And I want to say before you hear my concerns, and a lot of them are in our letter, not mine, my clients, both MedChi and the Academy of Pediatrics, they also have the similar concerns. We've learned a lot. The Senate hearing was yesterday, and then your hearing, and all of your questions were great for the department. But as we've listened through those answers to the questions, and as we've heard the testimony and had some conversations with the department, I need to raise our concerns, but they've got a lot more structure in what they think how they're going to run this than you could tell by reading the bill. So I'm hopeful that we can figure all this out, because the medical community definitely supports rapid and access and easy access for NPREP under circumstances where it's dictated. Our biggest concerns to begin with, which you had heard, which you've seen in my letter, and a few of you were kind enough to raise even in your questions, was that MPEP isn't just automatically okay for everyone. It's not sort of like Narcan. There's a lot of contraindications. If you're on certain medications, even if it'd be nice you could have MPEP, it won't work. That creates liver damage, kidney damage. So all those screening, testing, follow-up counseling issues, both physically, mentally, emotionally, all of those things are critical pieces of effective MPEP. Listening to the department talk about their connection to disease interventionists internal to the department, it made a reference to that in the statute, but really hearing how that works may take care of a lot of those concerns. We were very worried about an individual showing up at a pharmacy, getting their MPEP, leaving, and having no follow-up. I'm sorry.
Finish your thought.
One more component piece that wasn't raised by the department, but I know they're working on it. This isn't all scope. This isn't just anti-pharmacists. There's a part at the end of the bill that really hasn't been talked about, which would allow providers, including physicians, to have an agreement with a volunteer or an individual to dispense that part we have issues with. It's not a scope issue. And I think the department is working on that piece too, because it's not nearly as clear and clean as to how that would work with the disease interventionist. So we're looking forward to working on this in subcommittee, because getting it right is really, really important, even as we're trying to enhance access to NPREP.
Thank you. Questions? I see Delegate Bagnall reaching to the button. Oh, and I guess I missed Delegate Kaiser first. Thank you.
Thank you, Madam Chair, and thank you, Delegate Bagnell, because I pushed the button right when you got up there, because I've been waiting half an hour to ask you a question. I just wanted to, and thank you for both your written and oral testimony. In your written testimony, you addressed something I don't think you just brought up. Understanding that you're sympathetic to the issue, but you're saying you would love something that was rapid, but that this is not the best way to do it. Do you have an alternative?
Well, I think part of what I can adjust a bit from my written testimony, having heard what was envisioned for the program, which sometimes you read statutory language, you can't really tell it's that well thought out. The biggest concern we had was, how are we going to connect an individual who got their MPEP from the pharmacist to make sure they got all the ongoing care, counseling, testing, wasn't contraindicated, and so you didn't create unintended consequences? Well, understanding now this disease intervention person, the fact that they're going to literally call them, the pharmacist, that not all pharmacies are even going to be doing it, because some may not even choose to participate. So it was some of those issues created a lot of our concerns, and they're not clear in the statute, but they're clear in how the department has framed it in its testimony. So, I mean, I have to take it back to my clients, but I've been working with them long enough, and I heard the discussion long enough that I have a good sense that there's a lot of this here that is workable. Does it need some tweaking and clarification? Maybe strengthening and some parts maybe amended, but we're looking forward to working on that. It just wasn't clear when when the clients reviewed the language as it was written because of those issues. So we don't have a better idea. We'd like to make this idea work, but it's good. We just need to talk about it a little more.
Okay, Delegate Bagnall.
Thank you, Madam Chair. And to that end, I'm going to make the ask that you talk about it before the subcommittee. As we all know, health law is often written broadly for very significant and meaningful reasons. So if you could meet with them before subcommittee, so that any adjustments that we need to make are that we have a single bite at the apple.
We'll do the best we can, and I think that's probably achievable, but because they recognize many of the things we've raised, but had already thought through some of it. So I think that is very possible.
Wise words from the chair of the Public Health Subcommittee. We were all going to say it in unison over here. Any other questions? Seeing none, thank you very much for your patience and for waiting this afternoon and for being willing to work on this site. I think what I heard is this is a good idea that just needs to be completely figured out in a way to makes it safe and implementable.
Correct.
Okay.
Correct.
All right. Thank you. We now have 2 virtual witnesses. Richard D. Benedetto and Aaliyah Horton. Are they on? Okay. Everyone take a deep breath. They'll be popping up soon.
Hello.
Okay. Here we go. Thank you both for your patience and for waiting. We're going to start with Dr. D. Benedetto.
Thank you. Appreciate it. Hi, I'm Richard Benedetto. I'm a pharmacist working with HIV on the Eastern Shore, speaking in support of this bill with a few comments for amendments at the end. HIV is affecting patients throughout Maryland. Over 31,000 individuals have HIV infection in the state, and 751 new infections occurred in 2022, with the majority of these new infections being easily preventable with PEP or PrEP. Access to care really is scant, especially on the Eastern Shore. Not all providers feel comfortable providing PEP or PrEP, and pharmacists are well trained. They're accessible, they're capable of providing PEP and PrEP services. They understand the disease processes, they understand medication monitoring. They've been asked to provide testing and treatment services for at least the last 5 years, you've noticed with COVID, and they've undergone 5 to 6 years of education, including clinical training, to be able to do exactly these types of activities. PEP services are emergent. They must be initiated within 72 hours. It takes 2 to 3 months sometimes to get into most providers on the Eastern Shore, and that's not including specialists. PrEP services, while not emergent, require integration into the healthcare system that pharmacists are equally capable of doing. These services stop transmission. There's no doubt in that. But they're not readily available. Help pharmacists to be able to care for the patients that they know and work with regularly. What we need is the ability, like this bill provides, to be able to order and dispense these meds. We also need the ability to be able to order, perform, interpret, and relay the results of labs. We need the appropriate payment for the medications. Some pharmacists, including some hospitals, are not carrying medications because they lose hundreds of dollars on each fill. Also, note for the bill writers, protocols need to include 30 days because pharmacists can't just dispense the 28 days. And we need to look at payment for the service. Thank you.
Thank you very much for your patience. We'll bring Dr. Horton back shortly, I hope. But in the meantime, are there any questions for this witness? Delegate Bagnall, you're looking tentative?
I just wanted to follow up. Thank you, Madam Chair, on the 30 days versus the 28 days. If you could just clarify that statement.
Bottles for medication come in 30-day supplies. So pharmacists would have to open up a 30-day supply to dispense just 28 days, losing 2 of those pills, which, as you heard, $3,600 for a bottle. That's going to be over $1 or $100 per tablet. Pharmacists would eat the cost on that and lose it.
Thank you. Noted.
Thank you. Any further questions? Okay, thank you very much, Doctor. And we'll go to Dr. Horton now. Favorable with amendment?
Yes, good afternoon, and thank you for conferring the doctorate degree. But I am not a doctor, so I'll just say that. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. We are the professional society for pharmacists, pharmacy technicians, and student pharmacists in the state. And we are in support of this bill largely, and I have entered a support with amendment because there are just some questions that I think can be worked out with a group prior to the subcommittee, similar questions that Rich provided, as well as some clarifications from the Department of Health. But one of the things I wanted to mention is that I think the process in this bill really improves the access to HIV PEP and supports greater patient connections to the state's HIV education, care prevention, and support resources. And this is really going to be an entry point, not an end point. And I think the department has really clarified that. And I also wanted to emphasize that the protocols for dispensing PEP under these types of programs with pharmacists require that pharmacists screen patients to identify whether the exposure meets the clinical criteria and whether the medication can be initiated within the designated time frame. So there are pieces in place to make sure that it's appropriate. I did include in my testimony a written report called The Role of Community Pharmacies in Providing Access to HIV Post-Exposure Prophylaxis, which I believe supports the goal of this bill, as it's very specific to PEP. I'll also add that many of our community think that this bill should go further, but we recognize that this is a starting point. And I would also just emphasize that as we go through the details of this program, my hope is to work with the Department of Health and the Board of Pharmacy to ensure that the protocols are streamlined. As Virginia has a plan, has a process in place. And I just wanted to say, there's much more community pharmacy uptake across the chain pharmacy community when the laws and protocols are similar. They can be streamlined and put out to the community. Thank you.
Thank you. Good information. Are there questions for Ms. Horton? Delegate Alston.
Thank you, Madam Chair. I'm just wondering, you said you think the bill should go further. What do you think, in addition to what it's doing, that it should do?
Well, I will say this because I do not want to blow up this process, but this is the fourth time a bill of addressing HIV PrEP and or PEP has been introduced. And each time it's kind of gotten narrower and narrower. I think there's a growing understanding of the role of community pharmacies and pharmacists in this prevention area. And so there are states that allow pharmacists to prescribe PrEP and PEP. They include the authority to do testing so that pharmacists can do HIV testing. And so it's a part of that whole process. And there's been lots of obstacles to that. And so I wanted to put that out there to recognize that there's more that can be done within the community pharmacy space, but we recognize that this is a good entry point to at least get it started, start those connections, start building those relationships in the community on this particular area.
Okay. Thank you for sharing that, and thank you for sharing the belief that this is a good starting point, and perhaps we can build on it in the future. So, any further questions for Ms. Horton? Seeing none, thank you both very much for your patience and waiting to speak with us this afternoon, and for your time and testimony. With that is completes the hearing on HB 127 and the work before us today. We will be meeting again tomorrow for a full day of hearings. So be prepared for a long afternoon tomorrow. Thank you all very